This week on the BackTable podcast.
I'm telling you, there's just so much you can talk about this stuff because you can layer. I mean, for simple procedures, you can layer on the complexity, and like G-tubes is one of those things where people feel differently about it, and it's interesting because not only they feel differently, but they feel strongly about the way they do it. Yeah. And so that's what I've always found interesting about G-tubes is like, not only like do people differ on their practice patterns, but they're like, this is why I do it. And if you don't do it this way, peritonitis and death is right around the corner.
Yeah,
so
exactly. Yeah.
That's why I think like having this and like having the commentary will be very fun.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor.
Since I had my son, paying down my med school debt has become my top priority. I remember holding him in my arms for the first time, looking into his beautiful little face, and just wanting the best future for him. With the Laurel Road Student Loan Cashback Card, my regular purchases earn me 2% cashback when I use it to pay down my student loans, which helps me reach my goals faster and plan for my family's future.
Laurel Road for Doctors. Banking, insights, and benefits uniquely designed for doctors. See laurelroad.com/doctor checking for full terms and conditions. Laurel Road is a brand of KeyBank N.A. member FDIC.
Now, back to the episode. Excited to be recording from Paris, France. I got a good friend and colleague, Chris Beck, on as my guest today. Chris, how's it going over there in New Orleans?
Good. Thank you, Aaron, for having me on the podcast. Excited to be talking about G-tubes today.
Yeah, we're going to talk about G-tubes. You know what I was doing before we started recording? I went back and I listened to episode number 2 or 3, the one with Bream and Brandis. Yeah. And oh my gosh, those poor guys, the audio is so bad. And thank you, Peter Bream and Aaron Brandis, if you're listening for toughing through that. But it was a good episode. Those guys talked about techniques that I don't use. Actually, Peter was my program director at Vanderbilt. So I did learn the bag technique, the balloon assisted gastrostomy. But when I got it in practice, it just wasn't practical. And so I think you and I do G-tubes very similarly, which we're going to get into. I did also go back and watch your YouTube video, which I highly recommend. And I don't know if guess how many views you have of that video?
5,000.
11,000. Over 11,000. Pretty amazing,
I think
man.
I think maybe 20 of them are me, and then 50 of them are my mom.
And then your mom, and then Sherry.
And then it's hard to account for the other 9,000.
Yeah. No,
and then Sherry's family. Sherry's family might account for about 100.
Right. Either way, there's thousands of docs that have listened to it and watched it and gotten some out of it. And we're going to dive into a lot of that. But as you know, BackTable, we like to discuss these things, and sometimes little tips and tricks come out of it when we're able to get into it. So that's what we're going to do. The other thing I wanted to talk about was, Aaron, real quick before we get started, is Aaron Brandis's technique, which is the pull-through technique. Had you ever done that?
Yeah, we were trained on the pull technique. We had so many different attendings at Georgetown. We rotated through a couple different hospitals, and one of the docs there used the pull technique.
Yeah.
It's not exactly how Brandis does it, but yeah, trained in it. And it's like one of those things, like I know how to do the balloon-assisted gastrostomy. I know how to do the pull technique, but just what ended up working better for my practice was just, standard peel-away sheath and dumping in a G-tube.
Yeah. Once I got out in practice and I kind of saw how some of my partners were doing it, and and we're going to get into kits and all that stuff, but I realized that there was a very efficient way to do it. And when you have trained techs who know what to hand you next, and you you have a protocol that you go by every single time, it becomes pretty smooth. But things can happen, things can go wrong. And so that's what we're going to do today, is kind of talk through from the basics to a little bit more advanced stuff. So first of all, let's just start at the beginning. Where in your practice do these patients usually come from? Who are they referred by?
So a lot of our patients are referred from radiation oncology / ENT, patients with head and neck cancer. And so it's like head and neck malignancy, standard G-tube before they start radiation and surgery to get them some nutrition or get them ready to get extra nutrition. And then 80% of those are outpatient. And then we have about I say 80, maybe 90% of those are outpatient. And then 10% of our patients are inpatient referrals. There's a OMSF doc who does like these complex head and neck reconstructions, usually for malignancy, sometimes for benign disease. And those patients are sent to us, same reason, just feeding G-tube.
Got it. Yeah, similar, in our practice, a few of our hospitals are trauma centers, stroke centers. So a lot of times it's stroke patients or trauma patients who are kind of, failure to thrive, need a way to get some nutrition. Sometimes we'll get a head and neck cancer patient and they tend to be a little bit more, they're, more kind of walkie-talkie and you have more of an in-depth conversation with them about the tube itself. Usually we're talking to family about the tube and how to take care of it. So let's talk a little bit about. So I kind of touched on it was indications, but I mentioned.
Well, hold on. Do you get any movement disorders or like venting G-tube referrals?
Very rarely, but yeah, that has happened as well. Very rarely.
Yeah,
it's mostly stroke, to be honest. And maybe like people who have head and neck or either have an obstructing mass or they're like post-radiation or something like that.
Actually, I have a question, like going back to referrals, like do you compete with gastroenterology or is it like a collaborative approach with GI? Or, I was just curious about the referral or like the relationship with GI.
Yeah, I would say it's more collaborative because I would say hospitalists tend to just find whoever can do it fastest, and because they want to get the patient out of the they want to get the patient placed, right? So they want to get them out of inpatient. So gastrostomy tube a lot of times is the thing that's holding them up before they go to a LTAC or some sort of sniff placement. And so I would say it's more collaborative, and sometimes they try, they fail, they ask us to try, or vice versa. And most of them are coming via the hospitalist, maybe a neurologist and or oncology.
Oh, when you say vice versa, you mean you fail and then send it to GI?
I say we might fail and send them actually to surgery. So
okay,
that's a good
gotcha.
point. Not GI, because usually if we fail, then there's not a percutaneous option.
Right. Then
surgery will have to do it.
Okay.
Yeah, thanks for clarifying that. We never fail though, right?
I was about to say, I was like, man, it's almost sometimes like, IR has that mentality, like never say die. And I feel like I never send to surgery or GI, but I mean,
usually it's a scheduling thing. Usually it's like whoever can get to it fastest, which is good.
I will also say to our GI guys' credit, like the ones that I work with at the hospital, they rarely fail. Like we used to get referrals all the time in fellowship for like failure to transilluminate. And I absolutely never see that. I saw it twice with one of their younger partners, and I got the referral for like failure to transilluminate. And I called one of the guys I know, not the doc that referred it to me. And I wouldn't say he was mortified, but he's like, no, let me take a look at it. Let me take a look. And then they had put a new G-tube in that patient like within like an hour and a half.
Wow.
Yeah. So they also, like the GI docs that I work with, take a lot of pride in that, like they do not like to have to send to me.
Yeah.
It's a healthy competitive relationship, right. I would say. Yeah.
No, and that's a good thing. I mean, I think that it's
for sure.
There have been toxic cultures where it's more of a dumping kind of thing. Friday afternoon. Oh, they got to get GI punted it all week, and then they got to get them out before the weekend, and all of a sudden it's on our plate. And those are always annoying, but that's rare. We appreciate our GI colleagues, and so how about let's talk about contraindications when it's really can't do it. What would you say are the big ones?
Uncorrectable coagulopathy, which, in my practice, I do not see. Ascites, if there's something in the way, like an ascites picture with like peritoneal carcinomatosis, but those are the ones that kind of like, and I have to admit, I don't see uncorrectable coagulopathy. I'm not saying it wouldn't be there, like with some practice patterns, but not mine. And then, if there's something interposed between the stomach wall and then the actual stomach.
Yeah, because a lot of the times
also doesn't happen very much.
Yeah, right. The colon's in the way, liver's in the way, or it's just high up under the costal margin, under the ribs. Those would be the anatomic reasons. The anticoagulation thing comes very often because a lot of times they're stroke patients, so they're on aspirin or some sort of anticoagulation. As long as if it was like an ischemic stroke, that would be the main thing. Yeah, we just a lot of times we're just waiting for them to be off aspirin or Plavix or something like that.
And are they? I assume that they're bridging them in between that, right?
Yeah, usually they bridge them. If they were on, they'll bridge them on heparin or Lovenox. That's pretty much it. I would agree with you. Anatomy, although rare. So what do you do about anatomy, right? So a lot of times we review studies. We look and see, have they had a CT? A lot of times with the trauma patients, they've had a pan scan. So you can just look back, maybe it was a couple weeks ago. Does the stomach look like it's in a decent place for an open window? What do you routinely do a CT before if they don't have one?
95% of the time they have one because, these are head and neck patients, and a lot of times they'll get worked up with some kind of cross-sectional imaging to do a staging exam. But if I don't have anything, every now and then it's from an outside institution, I'll actually get one day of the procedure. I think there's a lot of ways around this. One, I don't think it's entirely necessary. I get it. It makes me feel better. And I know a lot of people will just say, get a cone beam when you're on the table, which is also an option. But I'll usually just, when they're in the pre-procedure area getting worked up, it's we have our patients come in so early. I think they come in 2 hours before the procedure. So it's just not that hard to get a non-con of the abdomen for me. It doesn't delay my start or anything. But if for some reason we had a tighter pre-op window, I think I would just do a cone beam on the table. But that does make me feel better having a little cross-sectional imaging to know that I have a nice safe access window.
Yeah. And in the video you mentioned they get barium. That's also routine?
Yeah, that's for me is routine. And it's still negotiable. Every now and then we'll have a patient that shows up that either they were a little bit confused on when to drink it or just didn't want to drink it or had trouble getting it down. And I'll still put them on the table and I can still see the colon, but it's just so nice to have that colon outlined in black whenever you're have them on the table. And once it becomes kind of one of the things you look for, whenever it's not opacified, it always has to be front of my mind, being where is the colon? I just have to locate it before I get going.
Yeah.
So having them take the barium beforehand is kind of it feels almost like idiot proof.
Yeah, I would agree. I mean, most of the time the colon has gas in it and you can sort of make it out, even if they haven't had barium. I would say in my practice or the hospitals that I cover, getting a CT ahead of time can be kind of a pain. So a lot of times it's just you get them on the table, you take a look at where the colon is, and then when you start pumping up the stomach, usually it pushes the colon out of the way, and you can kind of watch it. But the CT thing is, it to me, it's peace of mind. It's okay, this looks like a clear cut. There's an open window. And then sometimes when the stomach, it's like a little lady and the stomach's way up under the rib cage, I'll just say, hey, look, I don't see an open window. Chances are I'm not going to get one. Why don't you just have, general surgery? I don't know. It's tough, but sometimes or they have a big hiatal hernia. You don't even know that. Right?
Yeah.
And you're okay, have surgery, take a look at this patient.
Yeah. What about the post-op stomach? Do you ever get a gastric remnant that gets referred to you?
Yes, we have, and as long as it looks like there's a good window, more than happy to give it a shot. Never turned one of those down. We'll get into a little bit later. The only thing that I get that I don't like doing initially is GJ tubes, and we'll talk about that a little bit later.
Sure. If
they want a fresh GJ, I'll offer a fresh G, and then to convert 1 or 2 weeks later. But I don't want to get too off onto the GJs. So so anyway, workup's done. Patient's looking like a good candidate for a G tube. Get them down. What do you do when they first get over onto the table?
So I'll throw this out there, and I know it's going to be different than so many interventional radiologists, but I use MAC. I'll get anesthesia involved for a lot of my patients, and I know it's different. I know that I could safely anesthetize these guys 80 to 90% of the time, but a lot of my patients are these bad head and neck cancers, and sometimes even when you go to check their Mallampati score, it looks like they have a nice Mallampati, but then if you look at their cross-sectional, their larynx is completely eaten up by tumor. So there's 2 reasons. One, I like using anesthesia. I know the G-tube is not particularly painful, but anesthesia can put them out. They can do their thing. my anesthesia colleagues are also like very good about getting the NG tube in, which is my least favorite part of the procedure. So they'll get like everything teed up, patient super, super comfortable. The NG tube placement, one, it happens when I'm not in the room, so it saves me a little bit of time. And then also it happens while they're under anesthesia. And so from the patient's perspective, it seems like completely seamless. They just go to bed and then wake up after. They don't remember any of that stuff. So the first thing I do when I get in the room is just get scrubbed up and get ready to go. I do have ultrasound prep, so I will mark the liver margins, but I've gotten away from marking it before I insufflate the stomach. Like I'll go ahead and insufflate the stomach, and then I don't even mark the liver margins. I just kind of like find out where I want to go onto the stomach, and then I'll just check that area with ultrasound and a little bit above it, a little bit to the side. I'm just kind of like screening the area that I want to go. Like I don't necessarily have to identify exactly where the liver is.
Yeah, I think that probably saves a little bit of time. I mean, just to go back to the sedation, I use moderate sedation on all patients. I don't know I can't think of when I ever used a MAC, because they just tolerate it really well. And usually they're older patients and they're kind of lightweights, right? They don't require much. You just got to be careful. But that being said, it's not it can be quick and easy, but you're sticking that big old tube into their stomach. It's not a totally benign procedure. And so if you think that they're going to be squirming or they're not going to be able to tolerate it, then I would probably get anesthesia involved. And then that's a good point with the head and neck cancer patients, because they're already going through a lot, and you want them to be very comfortable as well going through it, because they're not, it can be a very painful procedure. So I think I have used it. I have used anesthesia when it comes to head and neck cancer patients, when I just want them to be completely out. When it comes to the liver, they put the patient on the floor of the table, and that's the first thing I do is I take ultrasound. I create that little triangle. I draw a line along the left margin of the liver, and I draw a line along, I feel the costal margin, and I create my little triangle. And that way I know my safety zone, where I can go. And then I start insufflating the stomach, because after that, but wait, just to take a step back, a lot of patients come down already with an NG tube in, but when they don't, then either myself or sometimes we have a skilled tech who'll put a compy down, right? I saw in your video, in your G-tube video, it was a compy. Did you place that?
I probably didn't. Either anesthesia will still use like a compy.
Okay.
They're comfortable. Yeah, they're comfortable using the compy if they don't have like one of their own NG tubes, or if it's like or they think it's going to be like an obstructing lesion, or sometimes like it's actually kind of I don't want to put it all on anesthesia because it's kind of collaborative effort. Like a lot of my techs and even some of the nurses, like a lot of them feel comfortable like giving it a go with the NG tube. Every now and then they have some trouble with one, and they'll get me to place it. But for a majority of my patients, like the NG tube's already in by the time I get in the room.
Yeah, that's great.
Yeah, I think that's sometimes
it's really
the
nice.
most annoying part.
It really is, especially if they're not sedated. And, so I always give them some sedation before we even start that. But a lot of times, it's the baby dose, it's the 1 in 50, and then, they're not totally asleep. And it's kind of one of the worst parts of the procedure. So they're already like all aggravated and upset. So you're right. And then sometimes they have, a tortuous esophagus or a patulous esophagus, and it's hard to get it all the way down. And what I'll do, I'll grab a glide wire and use that use the compy and the glide to direct it to get past any areas. Because a lot of times they can't swallow, or they're not willing to swallow. So you actually have to look lateral and see, okay, I got to direct this posteriorly so I can get past the epiglottis.
Yeah. I never actually look lateral. I usually have the patients, like I'll put it in the nose and then push their head all the way away from me, and then, just kind of keep probing posteriorly, and then eventually it'll go. Yeah. But yeah, it is a little bit, that to me is like the kind of the worst part of the procedure, which is another reason I like having them sedated and, out for this part. Or sometimes they're gagging depending on like what you're accessing, but for the most part, they don't remember any of that.
Yeah. Now, are you giving glucagon?
Yes, always give a milligram of glucagon. There are plenty of patients where I probably do not have to give glucagon, but they have it pulled, ready to go, and before we start insufflating, milligram of glucagon before we get going. Absolutely.
Okay.
Do you?
I don't. I guess it's offered, but I just don't find it that usually I I do it. I'm pretty speedy about my G tubes because once they start insufflating that stomach, I'm getting access real quick because I don't want that air all in the small bowel and everything. And so, because I don't want them to have to pump it up again. So I just don't. I just kind of streamlined my workflow so that I'm just kind of getting that access real quick, getting those T-tacks in, because it's for hypermotility, basically, right? It's just to slow everything down. Yeah. I mean, I think if I saw that somebody like the gas was just going right through them, then I might stop, give glucagon so that we can kind of, get some air to sit in the stomach. But usually I don't. What about antibiotics?
Yes. At this point, I feel like SIR has done such a good job with that app that just go to the app. If you have a question about antibiotics, go to the app. But yeah, so I give antibiotics pre-procedure, just SIR guidelines, pretty standard.
Yeah, I mean, it's a dirty procedure. So, you're crossing blood vessels and you're getting into the stomach. And I think it makes sense to do antibiotics prophylactically. We usually do, I think, a gram of Ancef is the 1 or 2 grams, depending on the patient's size. Okay, what's on your BackTable? What kit do you use?
So the kit is like kind of a compilation of things. Like the T-fasteners, I think they used to be from Kimberly-Clark. I think they're from Avanos. Is it pronounced Avanos?
Oh, yeah, you're right. I was thinking, because I looked back at your video and it is Avanos. Yeah. It used to be Kimberly-Clark, you're right.
Right. So those T-fasteners, I think those are really slick, easy to use. Yeah. They come with one extra. So if you drop one on the ground or you think one has some bad juju, you can use another one. And then I like the Kuhn's dilator set. I think that is from Boston side, but I'm not positive. So the set that we have comes with maybe 20, 22, 24 dilators, or maybe it's 22, 24, 26 dilators. I kind of forgot, but they're really slick hydrophilic dilators. And then peel away sheath. It comes with a couple different options. I think has a 22 and a 24 peel away sheath. And then I'll have a 20 French G tube on the table.
Oh, you start with a 20. Okay.
So actually, we used to do 16 French G tubes, and our radiation oncologist came to us and asked us if we would just start putting 20 French G tubes in. I say a lot, quote unquote, a handful of patients were getting blocked up G tubes, and Radonc thought that if we just started with 20 French, that might solve some problems. And our radiation oncologist asked very, very little from us, and so we decided to give it a go, and truly we followed up with them maybe 6 months afterwards and is this making a difference? And they're like, it's a huge difference for us. And so we just go straight to the 20 French, which I have to admit, 20 French is not, for me, not ideal. It changed the procedure just a little bit whenever you're doing that 24 French peel away sheath. And there's a little bit more kind of pushing. It's just not as much of a finesse deal as when you're dealing with a 20 French peel away for a 16 French tube. And for those out there, or actually I'm interested to hear what you say, I always have to go 4 French sizes bigger than the actual gastrostomy tube.
Okay, for your placement.
Yeah, are you doing just 2?
No, you're right, because otherwise it gets hung up because of that balloon.
Right. Mm-hmm. They do have some low profile balloons that supposedly can, if you do a 20 French peel away, you can do an 18 French G tube, or, an 18 French peel away for a 16 G tube.
Yeah, I use the Cook set but it's hydrophilic, dilators with the peel away sheaths, and I'm routinely an 18 French G tube placer, and so I use the kit that comes with the 22 peel away, and so it's for.
Is it the telescoping?
No, it's a hydrophilic kit. It might be because I think it's the same as the one that you showed in your G tube video.
Yeah,
but it's made by Cook.
Okay, I think actually mine is Cook now that I think about it.
Yeah, it's made by Cook. It's when that came out, I had a partner that he still to this day loves the transitional dilator, which is horrible. I'd almost rather do pull through technique than use that thing.
Some people love it. Some people love it.
It's because you got to gel it up. Yeah. And then when you gel it up, you're trying to push the telescoping pieces down, and it just slips out of your fingers. And so it's just so easy. You're literally, it's like 3 dilators and you're done within 5 minutes. I mean, they just made it so easy. It works really well. I agree with you. The 24, to go from a 22 PLA to a 24, there's something you just got to push harder. It just doesn't go as smooth. And we don't get many complaints about 18 French G-tubes clogging. Not to say it doesn't happen, but if it does, we can always upsize it later to a 20 once that track's formed. But yeah, I mean, that's what I use is the Cook set and a, super stiff Amplats wire.
Yeah.
Anything else that's on your back table?
No, I mean, after that, it's just syringes. I'll usually have them.
Yeah.
I usually have the ultrasound gel from the sterile probe. And so I like having that. Like, I don't gel up anything except for the gastrostomy tube, but I do put a little lubrication on the outside of the gastrostomy tube. I will say also, like, I use the Kuhn's dilator set, and I dilate up to 24 for the 24 French peel. Or actually, I think I dilate up to 26. I just go straight to the 26 dilator. Like, they have like a really, really smooth taper on them.
Transitional, yeah, exactly.
Yeah. And so I just go right to the 26, which I'm not saying it's not right or wrong in that respect, but I just like going single dilator, and then, you don't lose as much air, because sometimes it's a battle. Like, you're trying to get the tube and the PLA in quickly before you're losing a whole lot of air through like a really dilated skin site. Yeah.
So let's just like talk through, okay, the Cumpy or the NG tube's down, your borders are marked, you insufflate the stomach. Somebody's insufflating the stomach at the nose, and the stomach's insufflated. You start with your lidocaine, right? Let's start from the lidocaine and just walk through.
Yeah, so use lidocaine. Some people use ropivacaine or bupivacaine.
Usually it's lidocaine on my back table, but yeah.
I use lidocaine also. Yeah, so once I have the stomach insufflated, I'll check the liver margins, and then I'll put the hemostats on the patient, like over where I want to enter the stomach. And once I've kind of identified exactly where I want to be, and the stomach's insufflated to an adequate degree, and it's usually seems to be like half a liter is like the magic number, but that'll bring the stomach down, usually below the costal margin, and give me a nice safe access window, check the colon. And then I do boom, 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 lidocaine with like skin wheels at 3 separate, like all the spots. So I anesthetize all 3 spots, and then get rid of the lidocaine, and then scalpel for the 2 T-tacks, and then the single spot in the middle for where the gastrostomy tube's going to go. And then I'll take the hemostats, and then I'll spread open that skin nick for the gastrostomy tube. Like, that's like one of the most annoying things when you make your skin incision too small. And so always make sure that's like sized appropriately, and then I dilate down, or like I'm dissecting down. And then with the gastropexy tacks, I'll do half a syringe of contrast, so it's only half full. And then I like it connected to like a little short connection tubing, not a mini bore, but like a nice hardy connection tubing, and not too long, where I can put that T-tack down on the skin surface. I seed it just a little bit, and then I can still check with fluoro while keeping my hands out of it, like when I'm directly going down the stomach. You know what I mean?
Yeah, so you got 2 T-tacks in. The only difference, I just do 3 T-tacks, and that's just because for me, it's like 10 extra seconds, and it just confirms that I have that stomach up against a wall. So when I just feel like I don't have as hard a time dilating and getting the tube, the PLA in. But if the real estate is limited in that my window is small, then I'll just do 2 T-tacks.
Yeah, I think 3 is fine. 3 is good.
Most people I know do 2. Yeah, most people I know do too. My texts are always like, "What's this 3 stuff? It's excessive." And I'm like, "No, trust me, man. It helps me."
Yeah, I might even try the 3 on like an obese patient, because if you're telling me it gives me more pushability, like whenever that PLA sheath is going in, that actually does sound appealing to me. But I've always done 2, and 2 kind of gets it in. Now, every now and then, the reason I was thinking I'm open to 3 is there's every now and then when I'm putting that PLA in, and I'll pop a T-tack, like when I'm putting it in.
Yes,
and so,
exactly.
Yeah, and so having 3 doesn't seem like a bad idea. I think that just like speaks to one of the reasons, like how we do it differently, and how a lot of people do this differently, is that there's just so many good, efficient ways to put in a gastrostomy tube. And none of them are right, and none of them are wrong, and everyone's got their own reasons why they do their things. But like, there's just so many roads that get you to the exact same spot, which is like a safe, effective G-tube.
Well, and that's the whole thing. I mean, I learned it a completely different way in fellowship. And the way I do it now, I learned entirely from my partners and from experience in trials and tribulations and, trying new things, learning things from texts, and you just learn it over time. And so that's why I hope people kind of pick up a thing or two from our discussion. It's a great point about the obese thing. I mean, you live in Louisiana. I practice in Texas. Most of those G tubes are obese people, and either suffered a stroke or trauma. And but when it's a real skinny, small female or male, I will usually just do 2 T-tacks because I don't need, it's just not necessary.
Sure.
That stomach's already very close to the wall. So that's a great point that you brought up. So I want to know, this I think is important. What direction are you directing when you're going to you have your T-tacks in, you're putting your needle in for the actual G-tube access in the middle of those T-tacks.
Oh, hold on.
What direction are you going?
I wanted to back up and ask you, like when you're putting in your T-tacks, are you just straight AP, like going straight down, or do you ever rotate in the REO and do the stomach tenting?
So I have the tube straight AP, and I'm actually coming from an angle. So I know you go straight down, but what I do is actually, I do watch it, but my fingers are out of the frame. And, just like I'm aiming just to give it away, but just like I'm aiming every single needle towards the antrum. And when I get my needle in, even my T-tac needle in, I pull back for gas to get gas, and I inject contrast to see the rugae and confirm that I'm interluminal before I deploy that T-tac. And so I just always have it AP. I noticed from your video that the way you do it, and I think that's clever so that you can basically watch it tend.
So I will say, so if anyone goes and watches the video, we've referenced it a couple of times, I'll put it in the REO and I'll watch that stomach tent. But actually, I've kind of gotten away from that. I thought it was just like a nice thing to include. The reason I put it on the video is because I think it is sometimes nice, like when you really want to see or if it really matters, like you have a post-op stomach. But for like just routine things that I think like it's going to be really straightforward anatomy and the patient's not too obese, I just like dive bomb it into the AP and then just, as soon as you pull back and you get air, that's like almost confirmation enough. And then you inject the contrast and you see rugal folds. I mean, it's like, where else could you be? So I feel pretty confident, like just going straight AP is totally fine.
Yeah. Just an aside on that, position of the II, one of the guys in my group, he actually does the whole G-tube placement in the lateral position. He was trained that way because he said, this is how you never hit the colon. And I thought that was interesting. When you insufflate the stomach, you can confirm in lateral that yes, it's the stomach. It can be a little bit challenging when you have gas in the colon and the stomach, and then sometimes in the small bowel. It's like, okay, where, what's colon, what's small bowel? Because sometimes small bowel, when it gets filled up with air, can even look like colon. So you get it can get confusing. So he's like, I just do it all in lateral, and then that way my hand's out of the rays, and I can do it pretty. And then once he gets access, then he brings it back to AP and then does it the rest in AP. I thought that was interesting.
Yeah, no, I think that would totally work, especially if you were trained that way. I know that if I put the II in the lateral position, I would be completely disoriented. Yeah. So but if that's the way you're used to looking at it and you know what everything looks like and all the position of it, yeah, I mean, go for it. But if I put it in the lateral position, I would have zero confidence. I mean, not zero confidence, but it would be a little disorienting. So I think you have to get
sure.
I think you got to get a lot of licks in looking at it just that way.
I have used that trick at times when, like I said, gas just goes right through, and all of a sudden you can't tell what's what. And I'm like, okay, I just want to make sure there's not colon in front of my stomach, right, in my access, and so it helps confirm that.
Dude, give that glucagon.
There you go.
No one's gonna get hurt with glucagon
at that time. So we talked about how the direction of the of the access is important. You want to talk about that?
Yeah, so I go straight AP for my T-tacks, but then I'll angle it towards the pylorus whenever I'm going in for the actual gastrostomy tube placement. And I think anyone who's done a G to GJ conversion with like a surgical G tube knows how important that angle is. And so I'll always just give it, I mean, it's not like super steep obliquity, but just maybe like 20 degrees directed towards the pylorus, I think makes all the difference if you have to bring them back for a conversion. And if it stays a G tube, then, maybe you're out 2 to 3 centimeters in terms of length, but Maybe not even that. Maybe it's really more like a centimeter in terms of like extra length from adding that 20-degree angle to the pylorus.
Right. And the other thing on that is it just doesn't make sense to angle it towards the fundus, because again, you can keep your hands out of the ray as you watch everything go over the wire, right?
Yes.
If you're angling up towards the fundus, then basically to watch everything while you're pushing it, your hands are going to be right in the middle of the picture. So I think there's that advantage as well. But yeah, if they ever need a G to GJ conversion, then yeah, you might as well place something new if it's angled up towards the fundus, because good luck getting that to angle back. And
so
it can be really
have you ever
difficult.
talked to your surgery colleagues why they angle up? I mean, because that's exactly what they do. They angle, they direct their sticks towards the fundus. Have you ever talked to them about that?
I have not. Have you?
Yeah, I was like, why the F do you guys do this? This is a nightmare. And, one, they don't put a ton of thought into it, but they're taught that's the most anterior portion of the stomach wall. And so, if you want to make sure that you're intragastric, that's the shortest distance from A to B. And so that's why they direct it towards their sticks towards the fundus. It's got no regard in terms of potentially converting to a GJ.
Okay.
And honestly, I think if you talk to a lot of them, they're not aware that creates an issue downstream.
Yeah.
And I have to admit, not that I'm trying to change the surgeon's practice at all, but if you thought you were one was going to go to a GJ and you asked them to direct it, they'd be like, yeah, no sweat. They just don't put that much thought into it, if I had to guess.
Yeah. And then, you want that wire purchase to be in the antrum, right? You want plenty of wire purchase. And then that way, when you're dialing over that wire, nothing's coming loose, nothing's flopping back. It really helps to have plenty of wire down in coiled within the antrum. Sometimes it'll get in the pylorus.
Yeah, I was always taught that you fed enough wire in to where you were certain. It's just one more confirmation that you can see the wire touching two walls of the stomach. I mean, a lot of times you feed that wire in. I feed a ton of wire in, and then you can just see wire pushing on the lesser and the greater curvature. And one, you have a ton of purchase, and two, you're all right, know where I'm at.
You know where you're at, exactly. Yeah, It helps confirm that for sure. Okay, so you dilate, get the peel away in, tube goes in. You pull everything out except for the tube. How much are you putting? Saline, water, or sterile water? What are you putting into the balloon?
I want to back up because the whole crux or the whole finicky part of it is getting the tube through the peel away. That's when all the problems happen, or for me. So my problems happen when I try and put the peel away in. And so a lot of times it gets hung up. So you got to make sure your skin incision's big, and you don't want to be the last time you want to be futzing around with it is after you've dilated and now you're putting the peel away in and you realize your skin incision's too small. That's
right.
Not ideal. But sometimes I think it helps to reinflate the stomach, put some you've got the stomach incision or the track that you've dilated, tamponade it off with either one of the dilators of the peel away sheath, and then you reinflate the stomach. Trying to push into a deflated stomach, I think is where you can get into some problems.
Yeah, that's a good tip because usually I have enough air left, but you're right. I always pinch the peel away, and pinching it just to keep the air from coming back out and being deflated. But that can also crimp it, so it makes it kind of challenging to get the G tube. But I always pinch it so that all my air doesn't come escaping through it.
That's not a bad move, and I've heard of that. I think one of my partners does it. I don't pinch it because I hate it whenever I'm trying to stuff the G tube in and then it gets stuck in the peel away, which will happen. And so one of the things that I do, and everyone's got their own tricks, but when I'm prepping the G tube, I don't always prep every part of it myself, but one of the things I do is I will aspirate on that balloon, because if you just take it out of the package, it's just there's just a little bit of air in that balloon, and you can see it get compressed whenever you pull back on it. So I make sure I do that, and then I also lubricate the gastrostomy tube, and I think that makes it go through a little bit smoother.
Yeah. That reminds me of a funny story back to fellowship with Bream. I remember, I forget if it was a G tube or if it was like a fistula we were ballooning, like a stenosis. But I think it was a G tube, and I had it on the back table, and I went and I blew the balloon up on the back table, and Bream walks over and he's like, why the hell did you do that? And I was like, because I'm just making sure the balloon works, right? He's like, no, we don't do that. It's like, then you can't get it through the sheath. And I was like, oh, okay, that makes sense. And every time somebody brings that up, like getting that balloon to fit through, I always think about that. What a stupid mistake I made back in fellowship.
I don't know if that's a stupid mistake. It's very reasonable to test and see if your balloon works. I mean, that's like standard operating procedure for a lot of things we do. But yeah, you want it nice and slim. You want a nice slim G tube.
But we don't do that for angioplasty balloons either.
No,
you want it to stay slim, right?
Look, I'm totally with you. I was just thinking of that as I said it. But I was thinking about the minks or
yes, that's
all I
the
could
key.
think about was the minks.
Maybe that's
really.
what I was thinking of. Yeah. It's really just in that one case.
Yeah, I was like, it's just the minks. I don't think about it. But yeah, I mean, you're just testing your instruments. I mean, I think that's okay.
Yeah.
And then the other thing that I think is like kind of a trick that can bail you out every now and then is for some reason, like if your G tube's not going and your PLOA sheath kind of like falls apart on you, or maybe not falling apart, but maybe it's crimping, or you just have this like it's getting like compressed at the skin site, and you can tell. Sometimes stiffening up your G tube, have you ever done that?
Yeah. Yeah.
Okay. Yeah. So you can put a dilator into it. Usually it's like an 8 or a 10 dilator, or you can put, I think it's like a 6 or a 7 French 20 centimeter sheath, like a vascular sheath you can put inside.
Or sometimes even a compy. Sometimes people just even put like a compy inside.
Yeah.
Yeah. That helps add some stiffness to it when you're trying to get it through there.
Yeah. But honestly, when I do the PLOA, like I pull out the inner and the wire. So I've like bailed on wire access at this point. I don't know do you keep the wire in the PLOA?
I usually will pull everything. Yeah. So the PLOA comes off and then you just have the G tube in with the wire in, right? Mm-hmm. Yeah. So what I'll do is I'll connect my saline. It's usually just saline. I'll connect my saline to the balloon reservoir, and as I'll inject 5 cc's, and I'll start to pull back, and then I'll pull the wire out, and then I'll inject the rest. And so that it's snug. And then I was watching your video where you showed that you want to get a final shot, right? That shows the balloon, where the balloon is, that, make sure it's not, looks like it's not going through, your tube's not going through the colon. Mm-hmm. You inject a little bit of contrast for that final shot. One thing that I'll do at the end there to get a real nice, pretty shot is I'll actually have the tech or the nurse add more air via the compy, and so that the stomach's nicely inflated, and then you can really see your balloon really well, and you can really see your contrast go. And I'll save that cine shot where I inject the contrast, and it just shows it's nice, like intraluminal placement.
I think that's actually pretty slick. I like that. Yeah, I think like it's very important to get a final shot to where, I mean, because I think like no one would take them off the table if they didn't think that they were in the stomach. But I mean, like you want to make 100% sure, and then it's almost like you want to make 100% sure for anyone who wasn't there live that you were absolutely 100. Like that's how I think about it, is like, oh yeah, I know I'm in the stomach, like because there's a lot of like built in, like how the procedure went, but like if someone just had to look at your final shot, could they look at that injection, whether you do a single shot or whether you do a fluoro save of a cine, like can they look at your images and say, yeah, he or she was in 100%?
Yeah. No, that I learned that from one of the guys in my group too. Is I was watching him do a G tube, and every dilator pass, it's easy, just hit save for every fluoro, for any cine. So I started doing that just for documentation purposes, to show every step that I took. Here it shows that I was intraluminal, and I wasn't going through the colon, right? So I just started doing that just for good documentation.
That's good. That seems like a lot to me, but that's still
right.
That's still good.
It's taking up space, but
I mean, yeah, you're right.
Days, so.
Yeah, I'm with you. Data space is cheap. But the reason I say that is because I have a partner, like throughout the whole G tube, you get one picture, one single shot at the end, and it's like, this is where the G tube is. And I'm just, I mean, not right or wrong. I mean, he doesn't have any higher complication rates than anybody, but I'm just like, ugh. Like Bream, kind of drilled it into us that people will judge you on your pictures. And so I like my pictures to look good, high quality, collimated appropriately, and also to be salient, to you can follow what I was thinking as it was kind of happening.
And no fingers or hands in the picture. It drives me crazy
God.
when somebody's finger will sneak in and the tech will go to save and I'll be like, stop, slap their hand. Do not save that picture. We do not want to see fingers or toes or any appendages. That's just, no, it's bad photography.
I completely agree.
So let's talk about, so the tube's in. Do you cut your buttons for your T-tacks at that time, or do you just leave them there?
Leave them in. Does anyone cut them at the time?
People I know do. They'll they don't want to deal with, because people will come back with like little eroded areas, or not commonly, but if, they're supposed to fall out on their own, right?
Yeah.
But sometimes what happens is you get an aggressive tech and they tighten the rubber ring around it too tight. And then if you have a button underneath there, it kind of cuts in, it can cut into the skin, especially if they're already, if they have poor nutrition, they have poor healing, their skin's not great. So they will actually develop like some ulcers or your little, irritations there. And so I know people, because of that, they've seen that, they'll just cut it right there, because they're like, well, the T-tack doesn't really serve any purpose anymore. The tube's in, the balloon's there. And so I don't, though. I still trust that they're going to fall out, because I want to make sure that stomach stays pexied up against the wall.
Yeah. So
that if somebody starts feeding them too soon, or that, let's say that the rubber ring loosens up, you still have the pexi to help keep everything there. And so I leave them in until, and then they tend to fall out.
I'm in the exact same way. Wait for them to fall off. If they haven't fallen off by 1 month, then I cut them off. And I like them there also because, the ring can loosen up on the gastrostomy tube. I don't know. I feel like a lot of things can happen with the tube, but not necessarily a lot of things are going to happen with your gastropexy tacks. Like I would want them in there for like that tract maturation. But at the same time, I'm sure if people are cutting them and getting away with it, I wouldn't even say getting away with it. I'm sure there's some good reasons to cut them, and those patients also probably do very well.
Yeah.
So what do you put in the balloon? Sterile water?
10 cc's.
Saline?
10 cc's of saline. Yeah.
Saline? So you don't use the package insert recommended sterile water?
Usually the technologist hands me saline. I've never had issues with saline, knock on wood, but I understand the reason why it's water. I guess the balloon can start to, what is it, like it can mess with the rubber of the balloon or something, the saline, over time, but I've never had any issue. I don't even know what the reason is for the water. Do you?
I've heard a couple of different things. So like your three options usually are the sterile water, which isn't always as readily available on a BackTable as normal saline or contrast, or like some kind of form of dilute contrast. And I've heard that if you do dilute contrast or whatever contrast, then water, like osmotic pressure, will bring more water into the balloon. You could risk rupturing it. My answer to that, if you're actually worried about that, have you ever tried to inject too much water into a gastrostomy balloon to rupture it? They're hard to rupture. Right.
And I think I imagine that's the same reason why you do sterile water over saline, is because of the osmotic. Like, I guess if somebody drinks a bunch of water, then osmotically it could go into the balloon for the same reasons of the contrast.
Yeah, but I don't. That's one of the things I've heard. I don't actually know if that's the true reason. I've also heard one time someone told me the osmotic thing was BS, and it's actually because like the saline or the contrast will crystallize into the balloon, and sometimes it'll create so you get like a sediment buildup or something along those lines, and it actually makes it hard to...
And then you can't completely deflate it.
Yeah, then it makes it hard to deflate. I think these are both, in theory, things that can happen, but in practice, like I've seen people do it all kinds of different ways, with sterile water to saline to contrast straight up to dilute contrast, and all the tubes kind of end up being okay, or all the balloons end up being okay. Yeah.
Okay. Well, yeah. Again, no issues thus far with 10 cc saline. That's what we do. Okay.
Use the sterile water though. I do use the sterile water.
Oh, do you? So do they have to pull sterile water just for you?
Yeah. So they have to pull sterile water just for me. And I think I'm the only one who does sterile water. So they even have to remember it just for me. But like I tell my techs all the time, they're like, "Oh, you're kind of particular," and I'm like, and I used to tell them I'm particular because like everything's got a reason behind it. But it turns out I'm just kind of a particular guy, and I like it the way I like it, and I don't know how to explain it. So it's just particular. But I tell you what, it's like, if you have like your techs keeping track, like very like small details, like even if they don't get the sterile water right, they get all the other stuff right. And so sometimes I'm particular and it keeps them on their toes. I don't know if that's really true, but in my mind, that's what's happening.
Well, that's a good,
Yeah, because they know I'm a particular guy. They know, like, I don't let anything go.
Right.
Don't let anything go.
Right. So they're going to be on their A game when you're coming in for your G-tubes. All right. So post procedure, what orders are you putting in for these patients?
Inpatient or outpatient?
Inpatient.
Inpatient. So for the inpatients, don't use the tube for, I don't say 24 hours. I say don't use the tube until IR has cleared the tube. And so even if I put it at 8 in the morning or like 4 in the afternoon, I'll clear it whenever I'm making rounds in the morning. And so it just says, wait to use the G tube until IR is cleared. And I'll usually clear it first thing in the morning. Yeah. And then, these are all ICU patients. And so I don't have like a lot of things about bed rest. I don't have a lot of like pain medications, which would totally be appropriate, but they already have all this stuff in. So I'm not messing with their pain regimen that's already in place. And then I say don't use the nasogastric tube for 3 hours after the procedure.
Okay.
Like don't feed them until like 3 hours after the procedure.
3 hours. Wow. So I think I was trained at Vanderbilt. It was 24 hours, but in our practice, usually it's the next morning. So if there are no peritoneal signs like no pain, abdominal distension, or fever, then they're okay to feed them, to start using the tube the next morning at 6 a.m. So they could give them breakfast or their morning medications. So we usually will just wait like a good evening, basically. And then otherwise, sometimes they need an abdominal binder because their mental status isn't great. And we worry they're going to pull it out. So a lot of times I'll add an abdominal binder if they're old or senile. And then, the typical kind of post-sedation orders for vital signs and looking for signs of bleeding, stuff like that. Anything else that...
Hold on. So I know that, so I don't have them use the G-tube for 24 hours, but you don't feed them or anything? They can't eat? Or not eat, but they can't get feeding through their NG tube?
Feeding them? No, I'll hold off on that till the morning as well. Because, it's the same thing. If the tube's misplaced, then it's emptying into the peritoneal space. But also the same thing can happen from above where, you create this big hole. Let's say it was a complicated G-tube and you had to dilate or, grab another dilator. Let's say you had to dilate, grab another dilator and then pull one out. You create this hole. You may have created like a rip or something. I don't want anything in the stomach. And sometimes, especially when it's a problematic one, I'll actually put the G-tube to low suction just to keep that stomach empty through the evening. And that's probably overboard, but it just gives me a peace of mind that they're not going to develop a peritonitis.
I think that's totally reasonable. I see a lot of the low suction. Some people put the G-tubes to gravity. All those things are reasonable. So what about for your outpatients?
Outpatients, I always make sure they have a, home health care already set up, right? There's been a couple of times where I go to a community hospital and it's Friday and I walk in and on my board is a G-tube at 2 p.m. and it's an elderly person who has no home health care set up. They have no idea what they're having done. They were sent over by, somebody in the community and it just was not scheduled appropriately. I'm not going to put a G-tube in them, send them home, after everybody's gone and then they have no follow-up over the weekend. So that's the most important thing for me is to make sure that they have follow-up at home the next day. So they have to already have home health care set up before we even schedule them and so that somebody can check on them, make sure they're doing okay, get them to start their feeds and everything. So actually we'll talk to the referring doc about that if it's not already set up. But otherwise it's very similar. I don't want them to use it till the next day. I usually want them to kind of take a break. They can have clear liquids overnight, but I don't want them eating a big meal by mouth. Usually they can't anyway. They, at best they might be able to get Ensure, they might be able to get an Ensure or something like that. But I'm gonna have them wait till the next morning to do all that. So it's very similar. I really want somebody to be able to check on them other than a family member because family members don't know what to expect.
Man, don't your patients get really hungry? They've been NPO for the procedure and they have to wait till tomorrow. They must be so hungry. You have the hungriest patients
usually
in Dallas.
they're head and neck patients, cancer
I know.
patients. They haven't been eating for like weeks, and I let them know. I said, look, this is not a benign procedure. Like, you can get really sick if any of that food or ensure anything gets outside your stomach. You can get real sick real quick. And so I let them know, I'm sorry that I'm going to starve you till the next morning, but it's just for the sake of safety.
So for my outpatients, and we've changed on this, or like we've evolved on this a little bit, I think like when I was putting in my first G tubes, like I kept people overnight, which just like felt very excessive. But I mean, I for some reason I just did. But now like we've gotten to the point where keep them 3 hours after the procedure, don't use the tube until the next day, slow feeding protocol. They'll see dietitian or they'll see diet nutrition before they leave if they haven't already been plugged in with dietary. And there's a slow feeding protocol. A lot of these patients aren't ready to use their tube yet. Like we put it in before they've started radiation and surgery. So some of the patients are like still like it'll be weeks before they use their tube, sometimes months. And actually, so we'll keep them 3 hours, discharge, and then once they go home, I tell them they can eat.
Yeah, that sounds like they're feeling okay. I mean, but I'm like, you're going to have some post-procedure tenderness in that area anyway. Going to stuff this big old tube. And so I just let them know, like, if it gets worse, if you develop a fever, if your belly seems to be distending, just go to the ER. Just kind of basic stuff like that.
Yep.
That's pretty much it. And then I have them follow up, and then I let them know that the referring doc will probably send us, especially if it's an outpatient, send it back to us. Do you already schedule like a follow up for an exchange just to help prevent clogging or G tube complications ahead of time, or is it just you wait till they send them over?
So I usually wait for them to send them over. It would be so. And this is a product of like our patient population. So for the inpatients that we do with this one OMSF surgeon, a lot of these patients are like referred in. The reason we don't put the G tube in like a little bit ahead of time is because a lot of times they're coming from hours and hours away. And so they actually will have all their exchanges and like any maintenance of the G tube done at a different satellite area, not a satellite area, but just a different area. Like they're not going to come like 3 hours, sometimes out of state to have like a G tube exchange. And so all that's set up through OMSF, like for a 6-month exchange after we put it in, and it's not with me.
Yeah.
And then for the other patient population we have, which is very similar, they're all head and neck cancer patients. They're like under such tight surveillance with rad-onc that like a lot of times we'll end up doing an exchange for, I just have a low threshold to do an exchange. Like if the patient's like, oh, I'm having like some pain at the side and I think the tube wiggled out a little bit. And so I'm like, all right, come in. And then I look at the tube, I'm like, oh, we got to change it. Like I'm always like, if it's like 5 months, I'm just going to go ahead and change it rather than like take a look at it and then see him back in a month. But basically I want to hit that 6-month mark. And if we haven't seen them for one reason or another at 6 months, rad-onc will send them to us for an exchange. Or if anything happens sooner than that, then we'll exchange it out.
Cool. Any new tubes you've heard about or new devices? I feel like G tubes haven't really evolved other than the bag technique that Bream has implemented and trained people up on. I don't know of any new devices or techniques or anything around G tubes. Are you aware of anything?
I mean, I don't know. I feel like there's the slim G tube where you can get it in, you can get it through a smaller peel away sheath. You can take it a lot of different ways. You can, leave your regular MIC type gastrostomy tube in for like 6 weeks, and then you can kind of downgrade it to one of the MIC-E buttons, which some people like. Those are pretty slick. And what else was I thinking? I feel like there's all kinds of things with like tube management that you can talk about. Like one of the things that we do is I cinch the bumper down to the skin. I think it's important to have like a snug fit, like it's kind of like a friction fit, but not like too much where like the disc is like digging in on their skin. Like I think that can ulcerate. Right. But at the same time, it needs to be nice and snug to prevent leakage or reduce the chance of leakage. And then we've started putting, like I just bought like 100 or maybe 1,000 of them off Amazon. It's these little zip ties. And I'll put a little zip tie around the base of the disc, and that just keeps it from slipping a little bit. One of my partners this isn't like an advancement in gastrostomy tube. It's just like people do all kinds of different things with their G tubes to prevent problems. But he claims that like one of the main reasons we get referred like for problems with G-tube is someone tries to mess around with how much fluid is in the retention balloon.
Yeah.
And so he'll take a pair of hemostats and crush it. So no one ever can then access it. You can never access it from then on out. So if you ever, like if it comes to us, we can't like deflate the balloon or reinflate the balloon. You have to, you're committed to an exchange. Like you have to cut the tube to release the balloon water or saline or whatever's in there. And then you have to exchange it after you've cut it.
Interesting.
Some people will put tape over it, like just to say like a bunch of tape over it, like kind of indicating like, don't look at this, don't mess with this.
Don't mess with it. Yeah.
Yeah.
That's interesting. Where do you cut it?
You just cut it at the base, and then like there's a little piece of tubing that you just never see it, but there's a small piece of tubing that runs all the way to the balloon.
Put a wire? I guess, do you put a wire down just to maintain access? Let's say it's fresh, somewhat fresh.
If it were fresh, I probably would just to make sure I have access.
Yeah.
But most of the time, like if it's an established track, I just cut it, then put my wire down. Yeah, same thing like we do for a lot of tubes. Like like for a biliary or a gallbladder, you wouldn't put your wire in before you cut, or for a nephrostomy tube exchange.
Yeah, the Mick key is pretty cool because it's more flush against the body. And I know people that are walkie-talkie, like whether it's people that just have nutritional issues or maybe gastric outlet obstructions or stuff like that. They really like that when you're able to convert it for them, because it's not this thing sticking straight out. Mm-hmm. But it'd be nice to see some innovation in the field where it's a little bit, it reduces the amount of issues we have with tubes getting clogged without having to just increase the size of it, right? Or, some of the other issues are people just pulling them out. Like, is there some other way that we can secure it so that we're not getting, the ER is not getting like all these G-tube patients, coming in? Yeah, exactly. So I don't know. I just be for the audience, if you have any ideas or, want to talk about anything, any kind of innovation on G-tubes, feel free to write us in or message us on Twitter or leave a comment on this YouTube video. Chris, any last final thoughts?
Yes, I would actually be shocked if a lot of people did not comment in, because I think people have so many comments on G-tubes. It's like one of these procedures that everybody does them well. Everyone's got their own tips. Like, I think like for the patient, like just thinking about it, I think it's good to be able to put in G-tubes a couple of different ways. Like if you got a real player who wants to pull out their G-tube, like stroke patients, good example, pediatric population, you'll have patients who are just kind of pullers. I think like the disc, like the pull technique is a good option, because like those mushroom discs like that are on the inside rather than the retention balloon on the MIC.
Yeah.
I think that's a good option to have. Like a lot of in our practice, like that a lot of times goes to gastroenterology. So they're putting in the disc. I think those are way harder to pull out than our tubes.
Yeah. Even if there was like another material that wasn't rubber, that was something a little bit more almost like bionic, it would be interesting to see if there's any kind of innovation, right? Like imagine like a Tesla port, where the nutrition's being fed in a different way, but I'm sure it'll come along at some point. But for now, there's little things, but overall G-tubes really haven't changed much in the last probably few decades since they started putting them in. Definitely in terms of like issues with G-tubes, I don't think, after post-placement, I don't think there's been any improvement. I haven't seen any, in terms of clogging.
In terms of
in terms of them clogging, in terms of them falling out.
Oh my God. That's a whole like another podcast. I call it like whenever we have problems with the tubes, and like I just like summarize it and say it's just tubology. Like there's just so much to like. Let's do tubology. It. It's like clogged G-tubes, malpositioned G-tubes, pain at the G-tube site. Yeah. Cellulitis develops afterwards. There's all
sounds
kinds
like
of,
a follow. That sounds like a part 2. Let's do it.
Oh my God. Yeah. That's actually like, you're right. That's probably like something we should talk more about, because there's all kinds of little things that you can do. I remember like when we were fellows, like, one of the first things that we would do in the morning is go unclog all of our tubes that like we had placed. And it's like, just like nursing staff trying to like, ground up a bunch of medications and send like 30 pills through like a 16 French G tube. And man, I would just go with like I'd just have like a whole these 60 cc syringes like in my lab coat pocket, and I would just go and just like inject a bunch of air through all of them, just like blowing them clear every morning.
Yeah. And now there's somebody just like you doing it right now, today, probably.
I have no doubt, fighting the good fight.
Yeah.
Good doc out there. But yeah, like there was one more thing I was going to say. I would also be interested in seeing like everyone's commentary about like what they do with their G-tubes post-procedure, because I think like you'll see people all over the map. Like I bet you there's people who, for outpatient G-tubes, they send them home in an hour. I know that they do. And there's people who will keep you there overnight. There's docs who will bring patients back, and before anything is done, they'll do a second injection of the gastrostomy tube 24 hours afterwards, just to make sure it's still in the same spot before feeds are initiated. And so it's all over the spectrum. I know that I think it was MD Anderson. They came out with a paper talking about like early G-tube feedings. Like I think like it can happen as early as like 6 hours after you place a G-tube on an inpatient. So like it's early initiation of feeding or something. I forgot the name, but we can link to it. So I think there's people who are like all over the map in terms of how they manage this stuff afterwards. Yeah.
Well, I hope our audience got some out of today's discussion. And again, there are other ways to place G-tubes. There's, for any trainees out there, if you want to learn about the bag technique, Peter Bream's got a great video on YouTube. And then there was the pull-through technique, which I know some people are getting trained at their programs. I don't know if I'm going to recommend going back to episode 2. I don't think that that's a good idea. I think that you should just take our word for it that it was Peter Bream and Aaron Branders are amazing people, and probably just you direct Twitter them if you want to learn more about their techniques, but do not go back to episode 2. What do you think, Chris?
Yeah, I also listened to episode 2. It was a little painful listening to it. We've come a long way, but I think we probably just need to get Bream on to re-record it, like a remastered session. We'll get Brandis to talk about the pull technique, get Bream to talk about the bag. It's just too tough to listen to that old episode.
Yeah, those could be part 2 and part 3 of this one, and then part 4 tubology. Yeah. Who'd have thought we'd have like a G-tube university?
I'm telling you, there's just so much you can talk about this stuff, because you can layer. I mean, for simple procedures, you can layer on the complexity, and like G-tubes is one of those things where people feel differently about it, and it's interesting because not only they feel differently, but they feel strongly about the way they do it. Yeah. And so that's what I've always found interesting about G-tubes is like, not only like do people differ on their practice patterns, but they're like, this is why I do it, and if you don't do it this way, peritonitis and death is right around the corner.
Yeah, so exactly. Yeah.
That's why I think like having this and like having the commentary will be very fun.
All right. Well, great place to end it. Thank you to our audience, and keep an eye out for those subsequent episodes. I'll be reaching out to Peter Bream after this. All right. Thanks, Chris.
All right. Thanks, Aaron.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.